Hi, good afternoon. I'm really pleased to have the opportunity to get to do introductions today. And my name is Ellen Polishuk. I'm the academic chief of the Division of Collaborative Care and Wellness in the Department of Psychiatry. And I get to introduce our Collier Day lecture today. But first, before I do that, I asked the question to Dr. Rosenberg and Dr. Lee, who is Dr. Collier and what can we say about him? And with their help, I learned a little bit about who he is and wanted to share that information with you. So the Collier Lecture is an annual tradition of learning together from a leading researcher in the field of psychiatry. And Dr. J. Kirby Collier is a psychiatrist who specialized in the treatment of epilepsy. And he played a prominent role in helping to bring Alcoholics Anonymous to Rochester, New York. When he learned about AA, he traveled to New York City in December of 1941, attended AA groups, one of the first groups there, and launched one here by renting a room in the Seneca Hotel in Rochester in July 1942. Bill from AA had a quote about Dr. Collier and that he wrote to his widow when he had passed. And he said, when the society of ours was young and very uncertain in its struggle for survival, the doctor stood up before all the world to tell of his faith in us. This numbers him among one of the greatest and best friends that we have ever had. His name will always be a shining mark in the annals of Alcoholics Anonymous. So I thought that was interesting. Now I'm thrilled to have the opportunity to introduce you to our esteemed speaker today, Dr. Jurgen Unutzer. I remember when I first met Dr. Unutzer when I was junior faculty member here and had the good fortune to visit University of Washington and to meet with two of his colleagues there, Drs. Wayne Caton and Nancy Grote, both of whom were mentors and consultants to me earlier in my career and meant a lot to me. So I'm really pleased to have come full circle and that Dr. Lee convinced you to come visit us here in Rochester many years later. So Dr. Unutzer is an internationally recognized psychiatrist and health services researcher. His work focuses on innovative models of care that integrate mental health and general medical services, on translating research on evidence-based mental health care into effective clinical and public health practice. He has more than 300 scholarly publications and is the recipient of numerous federal and foundation grants and awards for his research to improve the health and mental health of populations through patient-centered integrated mental health services. Dr. Unutzer is professor and chair in the Department of Psychiatry and Behavioral Sciences at the University of Washington. He also holds adjunct appointments as professor in the School of Public Health, Department of Health Services, and Department of Global Health, and is affiliate investigator at the Group Health Research Institute in Seattle, Washington. Dr. Unutzer founded and directed the AIMS Center from 2004 to 2018. He was the principal investigator for the Improving Mood, Providing Access to Collaborative Treatment, or IMPACT trial, which showed that patients receiving IMPACT care were twice as likely to show improvement than patients in usual care. In more recent years, Dr. Unutzer's work has focused on developing local, regional, national, and global partnerships that support workforce development and capacity building in primary and behavioral health care. So before I pass it on to you, just a couple of housekeeping comments that Steve reminded me to share. For the Zoom audience, please use the QA feature for questions and comments. And also for the live audience, if you want to ask a question for the QA time, we will have time for questions. Please wait for the microphone. And there will be in the chat and emailed to you if you are here, the QR code for the evaluation. So please complete that. Thank you very much, Dr. Unutzer.
Okay, well, good morning. I guess for me, it's good morning. I'm 3 hours away from you guys, time zone wise. And good afternoon, and thank you for having me. It's a real honor. I've had a chance to meet a couple of you already to learn some about the really amazing work that you all do here. And I look forward to learning more about that. But for the next 45 minutes or so, I'm going to just talk at you with a bunch of slides. And I think there's a bunch of slides here in front of my presentation. I'm going to go through really quickly. That's our title. Okay. We've got some learning objectives. And I have no financial disclosures to make. Okay. And with that, okay. So this is my disclosure slide. I said my day job is I chair the Department of Psychiatry at the University of Washington in Seattle. I do some grant and contract funded research. All of that is listed on here. I don't do any paid work for pharmaceutical or device manufacturers. I don't think I have any other really important conflicts to disclose here. Before I say much more, I'm going to just do a little bit on where I'm from, just so you have a little bit of a context for some of what I'm going to say. So the organization I work for is called UW Medicine. It's a big part of the University of Washington, which is a big public university in the state of Washington. We have a very large academic healthcare system, about $9 billion a year budget, 30,000 employees, 5,000 trainees. And I think one of the things that makes us unique is we are the only allopathic medical school with a psychiatry department for a 5-state region in the Pacific Northwest. So we serve and train a workforce in psychiatry for the states of Washington, Wyoming, Alaska, Montana, and Idaho. And you can see that's a big geographic region. That's about 27% of the US landmass. And so that, I think, makes us different from some other departments. And that is the reason why I think we got fairly early on into saying there aren't ever going to be psychiatrists and psychologists in all these places. What else can we do to try to leverage what a psychiatrist or a psychologist might have to say? A little bit about our department. We have about 1,350 faculty, staff, and trainees. We have a good size, but not quite the same size, a clinical program as you all do here. We do about 100,000 visits a year. We have a pretty good sized research program, about $65 million a year in our research portfolio. And we have a very large psychiatry residency program. I think we now have the largest psychiatry residency program in the US. Our residents are in Seattle. They're also in Boise, Idaho, and in Billings, Montana. So we have a residency program that's pretty spread out over the Pacific Northwest region. So that's just a little context. So the challenge we all take on is the same challenge that you all have here. Mental illness and substance use are driving a tremendous amount of the health-related disability worldwide. And I think when I got into this business 30 years ago, people weren't really quite aware of that. And now I think we're quite aware of it. In fact, mental illness causes 5 times more disability than diabetes or heart disease, and 15 times more than cancer. And you might say, how could this be? Cancer is a terrible illness. It could even kill me. The big difference, and you all know this, but it's good for us to be able to say it when we make a case for what we do. The big difference is the kind of stuff we deal with comes at us very early in life. So by the time we're 14 or 15 years old, half of those of us who are going to live with a mental illness are going to have to present it with something. By the time we're 25 years old, it's 75%. And then if you're living with a really disabling mental illness or addiction problem for the rest of your life, that takes a lot of years, in terms of disability. And that's what makes it so different from, our colleagues who treat cancer and heart disease. Most of that stuff comes at us when we're in our 60s, in our 70s, maybe in our 80s. And then it can be a very bad thing, but it shaves off something at the end of your life. It doesn't sort of get in the way of you having a life. And I think people are increasingly recognizing this. In our region, we work with some very large area employers like Boeing and other companies, Amazon, Microsoft, and they have gotten very keenly aware of the fact that, an employee who's living with a mental health or addiction problem is a real challenge for them. Even somebody whose family member, say you're at work assembling an airplane, you're worried about your kid at home, your teenage kid at home who's not doing well. You're going to make more mistakes, and we have actually really good data on that. So employers have gotten very aware of this. Our governments know this. For the government, it presents differently. You are dealing with things like homelessness and people who are involved with the criminal justice system. And we've also come to realize, I think, just really in the last 15 years, that not only is mental illness a driver for morbidity, it's also a huge cause of mortality. I think we now know, and you all know this more than almost anybody, because you actually provide good medical care to patients with mental health and addiction problems. That's not something that we really appreciated when I was in training, that if you're, born here in Rochester, New York today, and you're going to develop schizophrenia or bipolar disorder, you're going to just shorten your lifespan by about 25 years. And you're not necessarily dying from a suicide, but you're dying from untreated hypertension and diabetes and things that we actually know how to take care of. I think those are the challenges we're up against. And how do we deal with that? So I'm trained as a health services researcher, epidemiologist, so I'm going to give you a little bit of clinical epidemiology. So let's say all those people on this slide, all those little people here, they're all the people who live in the United States today with a diagnosable mental health or substance use problem, something that there's a DSM diagnosis for. Or maybe it's all the people who live in the state of New York, or maybe it's all the people who live in Rochester. And how many of these people, they all have a diagnosable mental health problem, are going to have at least one visit with a psychiatrist in the next 12 months? What do you all think? Shout out something. One. Okay, that's it's not quite that bad. Pardon, maybe Rochester's really okay. All right, 10%, 12%. So 12 out of 100 people who are living with a diagnosable mental health problem in the United States today will see a psychiatrist at least once in the next 12 months. And I have to show this to people in my department. We have a couple of hundred psychiatrists, and I say to them, this is what you guys can do. You can help 1 out of 10 people, and how do we feel about that? And then people will say, well, wait a minute, there's a lot more to psychiatry, to mental health than psychiatrists. There are psychiatric nurse practitioners and PAs and psychologists and master's level therapists and pastoral counselors. And, if you take anybody who's got any formal training in helping a person with a mental illness, how many of these people will see somebody like that in the next 12 months? And the answer is 1 out of 5. So that's not so great. So I just told you a couple of minutes ago that this is 15 times worse than cancer in terms of its population health impact. How would we feel if we said that only 1 in 10 people who live with cancer in the state of New York get to see an oncologist in the next year? Probably not so hot. What if we said, 1 in 5 people who live with cancer get to see anybody who's got any kind of experience helping people with cancer? We would find that totally unacceptable, but that is kind of where we are still in mental health. Now, the good news is 40% of people, if they're surveyed, say sometime in the last year, I had a primary care visit where somebody, a primary care provider of some sort, did something for my mental health. Now, that's good news as far as I'm concerned. I'm a glasses half full kind of person. So to me, this is an opportunity. The bad news is, and this is the glasses half empty, 6 out of 10 will have had absolutely nothing, not even a primary care encounter to help somebody with a mental illness. So that's, I think, one of the challenges we're up against. We know that access is really challenging. In the United States, only about half of all psychiatrists who are in practice take any kind of health insurance. This is very unique in psychiatry. There aren't any other medical professions that I know of. Maybe plastic surgeons, maybe cosmetic surgeons, but most everybody takes people with insurance. We half of us, maybe half of those of you who are graduating aren't going to be taking insurance. How do we feel about that? And even if you do take insurance, it takes a long time to get to see a psychiatrist. And our colleagues in primary care are very aware of this. This data point on the bottom of this slide here, from a very large survey, primary care providers in 60 US communities were surveyed about their access to specialty care. And psychiatry was their #1 complaint. 2/3 of them said, it's kind of hopeless. I really can't get good psychiatric care for my patients. So I think this might be my only cartoon here. We couldn't get a psychiatrist, but perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. And this slide I showed in this cartoon I showed in a presentation at one of our primary care clinics during a lunch meeting with a bunch of primary care doctors. And the clinic chief said, hey, don't knock this dermatologist. So we actually have a dermatologist who comes here once a week. We love this man and our patients love this person and they'd like to see him twice a week. Nobody really asked me for a psychiatrist. So, okay, I was a little humbled. And she said, and by the way, I said, if you're looking good, maybe you're feeling good. So maybe the dermatologist is even good for your mental health. And there was an older gentleman who was an internist sitting in the back of the room eating his lunch, and he said, "Yep, it's going to look good going down." So I hope I haven't offended anybody too much, but this really is a challenge. What do we learn when we're learning how to be psychiatrists? When I learned how to be a psychiatrist, I learned something called a 50-minute hour. So the idea is you get in a room with a patient and you make a nice, hopefully you make a nice relationship. You learn about the patient, you make a diagnosis, at least a working diagnosis, you make an initial treatment plan, and then you wrap things up because you have another one of those coming up in about 10 minutes and you need to go to the bathroom and get a cup of coffee and maybe write a quick chart note. Actually, today, that's not a quick chart note anymore. Now they are charting in an EHR for a half hour after the visit. Anyway, so, and our residents say, I can't do this in 15 minutes. I need 2 hours for one of these. I'm like, you got to learn how to do this in 15 minutes or you're going to starve. But anyway, so a couple years ago, we did this in our research group. We did this interesting little analysis where we said, let's assume, and that's a very conservative assumption, that 3% of the population have the kind of mental health or addiction problem where they would benefit from having a contact with a psychiatrist at least once a month. And then what do we know about all the people living with mental health or addiction problems? What do we know about how many people are in practice in psychiatry? And if you do the math, if you're living in an urban part of the United States, we could give you 6 minutes a month with a psychiatrist. If you're living in the rural part of the United States, and much of the area that we serve in the Pacific Northwest will never see a psychiatrist, so you'd be like a minute and a half. If you live in Nigeria, it'd be 8 seconds. Just dividing the number of people who need a psychiatrist, into, the number of psychiatrists who are actually in practice. So this 50-minute hour is really important for us to know how to do it. I think we need to learn how to do it, and it's very interesting, but it's not a really terribly scalable answer for most of our patients. So what else can we do? So there are not enough psychiatrists. This is a map, a federal map on mental health care professional shortage areas. There is not a state in the country that has enough mental health professionals. The rural states have particular challenges. The map on the right is a map of our states. We have 39 counties in our states, and half of them have never seen a psychiatrist, a psychologist, or a clinical social worker. So once you get out into rural parts of the world, that's just not going to be the way you solve all these problems. So all I've done so far is spend 10 minutes telling you about all the terrible problems we have. So I'm going to try to shift gears a little bit and see what is it that we could do. So I'm going to touch on a couple of ways we could try to close these gaps. So we can try to train and also retain more people working in mental health. That's a huge goal. That's why we have a very large training program. And I think it's important not just to train people, but especially for the people who are working at a master's level. Not once you go all the way to a doctoral level, you're an MD or a PhD or another kind of doctor, you're pretty well committed and you're pretty well compensated. But the people who do this work with master's level training, bachelor's level training, it's hard work. It's a very high burnout profession, and a lot of people don't stick in the field. It's a little bit like teachers. So I feel like we need to also think about what is it that we can do to help retain people in this field. The other thing we have to try to do is there a way not to just work harder, but can we work smarter? And how can we leverage what we as mental health professionals have learned how to do? And we can do that a bunch of different ways. We've all learned something over the last couple of years about using technology to try to expand our reach. I'm going to talk a bunch about collaborating. And the other thing I think we could do is, and I'll just touch on that very briefly towards the end of the presentation, is there a way for us to move further upstream? I mentioned cancer earlier. When I was in medical school, I was training in the South, and people wouldn't want to say the word cancer. It was a highly stigmatized thing. It was a terrible thing. People were really, really afraid of it. In the same way that people are afraid of mental illness, I think, today, because it's scary. And what happened in cancer over this period, people started saying, can you prevent it? Can you treat it earlier? Can we find a stage 1 cancer, instead of a stage 4 cancer? I think a lot of what I see in psychiatry, by the time people get admitted in their 30s or 40s, to an inpatient unit in a psychotic state, we have missed a lot of opportunities to try to help this person. And I think that those are people who are sort of got the psychiatric equivalent of a stage 3 or stage 4 cancer. So are there ways in which we could try to go further upstream? And I think actually when you work in primary care, sometimes you see a stage 1 or a stage 2. By the time they come to us in specialty psychiatry, they're a lot more complicated. So when I was early on in my career, when I was doing a lot of consultation work in family medicine and in internal medicine, I'd see patients who were depressed and they were anxious and they definitely had psychiatric illness, but we'd start them on treatment and they'd get better. And I'm like, wow, people actually get better with these psychiatric treatments. When I see them in our psychiatry specialty clinic, they've been sick for a long time. They're very, very challenging. They don't always respond to the treatment. So I think there are lots of reasons for us to think about other ways in which we could try to move a little bit further upstream. So what are the challenges with training people? So we need to train more mental health professionals. It takes a long time and a lot of money to train a mental health professional. So a psychiatrist, minimum 12-year investment, psychologists, very, very similar. I think that's one of the real barriers. So we have thought, over the last couple of years, are there other ways in which we can take some of the skills that we learn as doctoral level psychiatrists or psychologists, can we share them with other people? So my current thinking is that what we really need to do is we're never going to have enough psychiatrists and psychologists. So who else can learn some of the stuff we need to know? Everybody should be able to learn it. I think ideally the person living with the illness should have the knowledge and the skill. And maybe if they can't do that, maybe the people who are in their lives, patients, family members, peers, community health workers. So we've invested a lot of effort over the last couple of years to say, can we train others to be part of the mental health workforce? And there's a whole bunch of other people on this slide. I won't go through all of it, but we've made a really big investment to say we need to get outside of the silo, and we need to really think about ways in which we can engage and train and give skills to other people who are in our patients' lives. One of the other approaches we have taken is to say, if we don't have enough psychiatrists to see everybody, and we realize that 40% of patients with a mental illness get seen in primary care, what can we do to partner with our colleagues in primary care who often have the patient in their office? And that's where this notion of collaborative care comes about. And many of you know this, some of you are practicing collaborative care, so I won't spend too much time on this, but the idea is basically you have a primary care provider and a patient. And what we said is that person needs some help because on their own, with a typical day of a PCP, it's very hard for them to do a heck of a lot treating mental illness. It's kind of overwhelming. So we said, what if we gave them somebody on their team who can help manage some of these patients? And what if we didn't give everybody a psychiatrist, but we gave this team a psychiatric consultant who could help out when people are not improving? And what would we do with this care manager? What do they do? So we said, we'll teach them how to measure things, because I spent a lot of time early in my career working in primary care, and I learned a lot from what my primary care colleagues did. So when they're treating somebody with diabetes, they're not just saying, how do you feel your diabetes is doing? That's what we do. We say, how do you feel your depression is doing, your anxiety is doing? They're saying, let's see what your A1C is, and I said, hey, stuff can be measured. And if you measure it, sometimes it really helps. So we started saying, if we're going to treat depression, everybody who gets seen for depression in that clinic should have a PHQ-9 every time they come in. If we're treating anxiety, we track on some anxiety tool. And then we said, what do we have for treatments? Well, this doctor can prescribe a medication, but oftentimes the medication might help you a little, but you need something else to change your life. So can we teach somebody in that clinic how to do things like motivational interviewing, problem-solving treatment, behavioral activation, simple, evidence-based, very effective, brief psychological interventions that we can provide right in the primary care setting. So we train nurses and social workers and people who worked as care managers in these clinics on how to do that. What else do we need to do? We said, how do we know if patients aren't getting better? So we put everybody in a registry tool where we could very quickly call up for this primary care provider, who are all this person's patients who are in treatment for depression, but they're not yet getting better. How would you know that? If you have a panel of 1,000, 1,500 patients, you can't keep track of that. But if you have a registry tool, you can pull that up just like that. And then we said, what do we do with the psychiatrist? Well, they can't take care of all those patients, but what they can do is spend 2 or 3 hours a week and hear about every person in the registry who's not improving. And what did then the psychiatrist, what do I do when I'm that psychiatrist? What I do is I say, maybe we got the diagnosis wrong. Maybe, we have the right diagnosis, but the treatment's not working. Let's make some changes. And I don't have to spend 50 minutes with the patient often to do that. I can hear about it and I can make a good suggestion. Or I might have a very focused question. I might sort of say to myself, I wonder if this is not depression, but it's bipolar depression. And this person who's been put on an antidepressant is actually kind of in a yucky mixed state right now. That's not going to help them feel better. But I could, do a very focused exam that could be in person or it could be by telehealth. I could find in 10 or 15 minutes, is this a bipolar depression or is this unipolar depression? So there's a lot I can do as a psychiatrist if I have all of the other tools in place, to help improve the care. And that's the model that we tested. And how well does this work? We've done a lot of research on this. I'm just going to show you one slide. This is from the largest study of collaborative care that we've done to date, called the IMPACT study. And what we did there is we took 1,800 depressed primary care patients, people who met diagnostic criteria for major depression, and we randomly assigned them. They were in 8 healthcare organizations in 5 states, and we randomly assigned them to get usual primary care or to get collaborative care. The orange bars are collaborative care, the blue bars are the usual care. So in every clinic, we had about 200 patients, 100 of them, all seen by the same primary care doctors. 100 of them, we gave them this model of care. And the other 100, we said to the doctor, your patient has depression, do anything you can over the next 12 months to try to help improve them. And so what did these doctors do? 75% of the time, they pulled out a prescription pad and wrote an antidepressant prescription for their patient, for the usual care patients. 25% of the time, they said, this is too hard. I'm going to refer you to mental health. And a year later, we looked at all of these patients and we said, how many of them have a 50% or greater reduction in their depression severity from their baseline when they came into the trial? And those are the numbers up here. So in usual care, on average, 19% of the patients who were treated in primary care had a significant improvement in their depression. With the collaborative care model, we more than doubled that. We didn't cure everybody, but that's a pretty significant effect. And when I showed this to my colleagues who are working on things like hypertension or diabetes, they said, if you had something that could double the likelihood that a diabetic patient gets better, you'd be getting a Nobel Prize. That's really amazing. And I think if you do this well, you can make a big impact with a collaborative model like this. The other thing we learned is, this is not something we set out to learn, but we learned it. We had really good data on healthcare costs for all the patients in this study. We followed all these people 4 years after the original study. And one of the things we learned is that for every dollar that we spent on providing the collaborative care services to the patients in our intervention group, we saw $6.50 in reduction in total healthcare spending over the next 4 years. So for the people who were in an HMO like Kaiser or the VA, those organizations loved it. The people who were in very traditional fee-for-service organizations like Duke was one of our study sites. They made a lot of money selling expensive healthcare. They didn't necessarily love it because that's how they make their money, right? Selling expensive healthcare. But, most people said, hey, that's not a bad thing. If people are using that much less healthcare, you did something good for them. This got a fair amount of attention at the time that we published it. It got a really nice article in the Wall Street Journal. This is probably something I've gotten more attention for than all the other articles I've published in the New England Journal and in JAMA. So if you really want to get someone's attention, write about money and put it in the Wall Street Journal. It'll get people's attention. The other thing we said is, okay, this worked really well. We did a whole bunch of other studies that I'm not going to show you, but there are now 95 studies, I think, that have taken essentially this model of care and said, is this better than usual care? And it is. But I was really kind of obsessed with this notion about, could we go further upstream? So we had a really nice opportunity about a decade ago in our county in Seattle, King County. We did a partnership with the Seattle, the Department of Public Health. They run a network of 14 community health clinics, primary care clinics that serve low-income patients. And they had a program that served essentially a lot of low-income mothers. And so we said a lot of these, low-income mothers in these clinics are struggling with depression and anxiety. Could we do a model like that for them? So we put collaborative care into 14 of these clinics. We treated 2,500 low-income mothers with diagnosable depression. 34% of them had thoughts of suicide at the time that we put them in the trial. These were not people who were the worried well. These were people who were really depressed and struggling quite a bit. And we said, how well does this work? So this, I need to explain just a little bit. This is a survival analysis. And what we had there is, this was not a randomized controlled trial because this was funded by the county. This is real healthcare. This wasn't a big research study. But what we had is, we had data on the moms that were treated in these clinics before we put this model in place. And then we had data on the moms that were treated in the clinic after we put the model in place. And so the blue line is the patients before we implemented this model. And what you see is it took about 60 weeks on average for about half of these mothers treated in this clinic to have a significant improvement in their depression. So that's what a survival analysis does. It just says how much time goes by until a particular endpoint is reached. Usually these are done for until somebody dies. In this case, we said how much time goes by until half the people, have a significant improvement in their depression. And before we put this model in place, it took about a year. After we put the model in place, same doctors, same kinds of patients, we were able to shift that curve way over to the left. So there's 600 patients in that red line. And it took on average 10 weeks for half of these patients to no longer be significantly depressed. That's a huge difference if you're, pregnant or if you've just given birth to a child. The Mayo Clinic was not involved in any of this original research. And they said, well, our care is really good, but let's implement this and see if it works. And they published a really nice paper that basically said they were able to get the time that it took to get a depressed Mayo primary care clinic into remission from depression from about 600 days to about 86 days. So even in a place that thinks that it has really good healthcare, if you organize it and if you do this well, it can make a really big difference. Then we got a little more ambitious. We said, all right, this works for depression, it works for anxiety. But our colleagues in primary care were saying, we don't just have depressed and anxious patients. Some of our patients have much more severe illness. They have bipolar disorder. They have PTSD and depression. Would have worked for them. So we had opportunity to do a really nice trial. John Fortney, who's one of my colleagues at the University of Washington, is the PI on this trial. It was funded by Collier. It was a pragmatic study. And what we tested is, can you apply this kind of an approach facilitated by telehealth for patients with bipolar disorder or PTSD in rural primary care clinics? So what we tested there was a little bit of a different approach. We said in one arm of the study, people will get collaborative care, just like I explained, with one addition. In the earlier collaborative care study, the psychiatrist didn't need to see all the patients. Here we felt like the psychiatrist needed to see everybody at least one time, just to make sure we get the diagnosis right, because bipolar disorder is a little bit more challenging, I think, in primary care to really diagnose well. The alternative arm is a very traditional specialty arm. So we had everybody who had bipolar disorder and or PTSD treated by a psychiatrist and a psychologist, with the one exception. These were all rural clinics, so all of the care was provided by telehealth. So you got telehealth specialty care, or you got collaborative care. We had some great partners in this. We tested this with academic partners in Arkansas and Michigan and in the state of Washington. We screened over 3,000 patients for this trial. We enrolled 1,000 patients. 1,000 people got randomly assigned, 500 of them to the telehealth specialty care and 500 of them to collaborative care. And then we looked and see what people actually got, what they actually used. So for the people in the telehealth specialty care arm, you can see on the right side, they had about 3 contacts with a psychiatrist and 3 or 4 contacts with a psychologist. So they got specialty care. On the left side, in the collaborative care arm, they all had about one visit with a psychiatrist and then a whole bunch of contacts with our depression care manager in primary care. And their med management was all done by their PCP with some advice from our psychiatrist. And these are our primary outcomes. So the primary outcome for this trial was the mental health component summary score on a scale called the SF-12. It looks at mental health functioning. And for those of you who are not familiar with this scale, it's normed. So 50 is a healthy population norm. And then a 40 would be one standard deviation lower than the average population. The average score for people coming into this trial was a little over 20. So that's 3 standard deviations lower than what a healthy population should look like. This is a very, very ill group. And what you see is in both of these groups, we saw really substantial improvement in mental health functioning over the next 12 months. We had some secondary outcomes we looked at. We looked at PTSD symptom severity. We saw really nice reductions in PTSD symptom severity and really not much of a difference between the two groups. We looked at how much time people spent in a euthymic state, so not being depressed or manic. And again, pretty significant improvement in that as well. No big differences between the two groups. We looked at other things. We looked at medication side effects. And the interesting thing here is in most medication trials, you see the medication side effects go up during the trial. Here, these were people who were already taking a whole bunch of psychiatric medications. And once you give them better care, actually, you see some reduction in the medication side effects over the course. Sorry, I'm going a little too fast. So what we learned there is actually even with a fairly complex group of patients, you can help them with a well-implemented collaborative care model. The one thing I would say is from the perspective of how much psychiatry it takes, it took about 6 times less psychiatry and psychology time to help with the collaborative care model than it took with the specialty care model. But we really got the same outcomes. So I feel like it makes some case that even more severe conditions, if you resource it properly, implement a model like this properly, you can really help quite a bit with collaborative care. I'm going to shift gears for just a moment. So I've talked a little bit about collaborative care. But as I mentioned, in the original impact study, we got a lot of patients better, but we still had patients who didn't get better. And so we started thinking, what would it take to get more people better? So we said, who else can we partner with? And this is a more recent trial. That paper is still, is about to get published. And it was a trial funded by a foundation in California called the Archstone Foundation. It's called the Care Partner Study. And what we said is, for people who are in primary care, they don't spend all of their day in a primary care doctor's office. They spend the rest of their time in the community. What if we found organizations out in the community that could provide some of the care in partnership with a collaborative care team in primary care? Excuse me. Could we improve access to care? Could we engage patients better in treatment? Could we actually provide some of the treatment in the community? So innovation here was to go from the traditional collaborative care model and add a community-based organization that works in the community who could provide some additional care. And the kind of roles we thought that our community partners could have are things like reaching out to patients, helping us with identifying patients in the community, maybe doing some patient education, helping patients with medication adherence. And then can we even teach people in the community to do brief psychotherapy? Do you have to really go to a doctor's office to do that? Or could you do that in your home, with a community health worker? We enrolled about 800 depressed older patients in this trial. And you can see they had a really nice, this was in California. This project had a really nice ethnic distribution. We had 40% white Hispanic, 40%, about 30% white non-Hispanic, and then about 10% mixed or African-American Black patients. And then we said, what did people get? All right, so on average, people had 10 contacts with somebody from our team. 90%, 89%, almost 90% of the patients stayed in care had at least 2 contacts. 75% of them had not just collaborative care and primary care, but they actually had at least 3 sessions with somebody who was one of our partners from a community-based organization. 75% of them had 1 or more psychiatric consults. And then the pandemic came. This was right in the middle of the pandemic, and we're helping depressed older adults, and everybody sort of crawled into their houses. Nobody wanted to go to see anybody. It was really, really challenging. So we had to kind of midstream revamp this project a little bit. And we found out that there were so many of the older patients we'd been working with and we'd been bringing into the primary care clinics for this care who were getting more and more isolated, and the depression was getting a lot worse. So we kind of retooled the project and thought of a lot of ways in which we could find ways to help people stay connected. So we developed this thing called the Stay Well Plan for people. We did a lot of telephone care. We did a lot of telehealth care. And at the end of the day, a year in, what we found is that 70% of the patients who came into this trial had a significant improvement in their depression. That's substantially better than what we saw in the original IMPACT trial. So we do believe that actually we were able to, with a good community partner, leverage what we were able to do with collaborative care in the community and get even more people engaged, get even more people to benefit from this care. So I have about 10 minutes left, and all I've done so far is talk about problems we have. I showed you some interesting research about what we could do about it. But now let's talk a little bit about the real world, because the real world is not what happens in our research trials. So I'm in a large academic healthcare system, and we were doing this research, and we weren't doing this very much in our own healthcare system. And so at some point I started saying, I need to start doing this, not just in research trials, but we really need to do this. And so we started rolling out the collaborative care model to now well over 20 academic primary care clinics that are part of our academic healthcare system. We also did a really great partnership with a managed Medicaid organization that works with community health clinics throughout our state. And we said, there's about 100 primary care clinics throughout our state that are community health clinics, FQHCs, clinics like that. Every one of them could have a little collaborative care team. And we partnered with this insurance plan, and we offered collaborative care to more than 50,000 patients in more than 100 clinics throughout our state. And we kept track of all of the data. And I don't have the opportunity to show you all of the data, but essentially, we were getting outcomes, clinical outcomes, almost as good as what we saw in our trial. So this was actually quite effective, and we have psychiatrists in our department who would do this 2 hours a week, 4 hours a week. Every one of us had a couple of clinics that we were assigned to as collaborative care consultants. And when I talk to my colleagues who are doing this work, they really, really like it. And what I hear from my colleagues from our psychiatry faculty who are doing this work, when they're partnered with a clinic or two, they're saying, this is different because I realize that I'm helping so many more people than if I just go to the outpatient clinic one more afternoon a week, because there I can see 2 or 3 or 4 patients. When I spend 2 or 3 or 4 hours with a collaborative care team in one of these clinics, I'm helping 100 patients. I'm having a huge impact because I have a team who's doing most of the work. And I'm just really called on to make sure we get the diagnoses right. I'm getting called on when people are not improving. And the other thing that they will say is, most of us like to be smart. And as a consult doctor, you're always smart because you always know a little bit more than the person who consulted you. And so when you're talking to somebody and you're giving them advice, they say, thank you. Your patients don't always say that when you're in clinic. And this is really, really rewarding. And people say, I love this because I'm not just helping this one patient, I'm teaching. And these doctors I'm working with are really smart. And if I teach them how to do this with one person, they'll do it with the next 10 people they see. So there's something really, really satisfying about that. We started thinking about 20 years ago, actually, after we did some of the initial research. It's one thing to do this in research. It's actually really hard for organizations to take this, implement it in very diverse real world settings. So we developed a program in our department, AIM Center, stands for Advancing Integrated Mental Health Solution. And the AIM Center isn't about doing research. The AIM Center is about helping organizations all over the world to say, if I want to implement this, how do I do it? What do I need? How do I train people? How do I bill for this? Lots and lots of nuts and bolts stuff that you need to do this well. We wrote a little book about how to do this. We've done a lot of training in our state. We started in 2015 with a little grant from our state. And 6 years later, we had trained collaborative care teams in all but one county in our state. So we have one holdout, that's Garfield County in the south east of our state. There's 2,800 people who live there. So it's not a super populated area. We have developed an ECHO program. I don't know if you all do ECHO here. We have a psychiatry and addictions ECHO that is statewide, that is now actually in its 8th year. It's super popular. We got a grant from CMMI to train psychiatrists in how to do this. And we've trained about 3,500 psychiatrists all over the country, because people don't learn how to do this in residency. Maybe that's different here because you all have exposure to primary care psychiatry here. But most people who graduate from a psychiatry training program, they do not have the skills to do this kind of consultation. It's very different work from doing those minute hours. And then a couple years back, we sort of had a really nice opportunity with our governor in Washington State to say, if we really wanted to invest in having a better reach for Washingtonians with mental health problems, many of whom live in these counties that just do not have access to specialty care, what could we do together? And the governor invested a huge amount of money in a partnership with us to do this. So some of it's going into workforce development. We grew our psychiatry residency. We grew our child psychiatry program. We started to build residency or fellowship programs for nurse practitioners and physician assistants. And we've also started a program that trains people who are undergraduate students as behavioral health support specialists. This is a program where you're learning as an undergraduate psychology major how to do psychotherapy. Most of it's the #1 major at the University of Washington, undergraduate psychology, and most of them are graduating without any clinical skills. And so we said, could we give them some clinical training? Could they do things like, motivational interviewing, cognitive behavioral therapy? And it turns out they can. This is not rocket science stuff. And so now we train in 6 public universities in the state undergraduate students to do evidence-based therapy. And our state has developed a credential that licenses those people, and they can actually bill insurance for that. The other thing we said is, can we build consultation services, and can we build a nice facility to train people in how to do this work? This is our new Center for Behavioral Health and Learning. And as I am here today is the first day that we're seeing patients in this brand new center. This was a $250 million investment that our state made. Built us a beautiful facility that has on the 2nd and 3rd floor 50 medical surgical beds for people with psychiatric illness, much like what you have here. And all the upper floors are geropsych and adult psych. And on the bottom floor, we have a really nice neuromodulation program that does ECT and TMS and other kind of interventions. It's a great setting for us to train people. The other thing we have there, as I mentioned, we have a big neuromodulation program that's part of this program. And the other thing we run out of that facility is an interesting program where we make ourselves available to any healthcare provider in the state of Washington, 24/7, 365 days a year. So a pediatrician, an internist, a nurse practitioner, a PA, anybody who's taking care of a patient with any kind of mental health problem can call us 24/7, 365 days a year and say, I want to talk to a psychiatrist. And what we do is we don't see the patient for them. We'll give them all the time they want to talk about the patient, to give them advice on what to do with the patient. Okay, this is it's timing me out, but that's good. And this has been super popular. Our clinicians really enjoy it. We take shifts on it. I take shifts on it. We cover that at night. We cover it during the day. We get a lot of calls. It's super popular. And we have a particular subcomponent of this program, which is intended for perinatal psychiatry. Some of the calls we're getting, on women who are in the peripartum period are very challenging for me as a general psychiatrist. I got a call on a Saturday evening about a young lady who was in an ER. The person who called me was the OB who was taking care of her. She was in her second trimester. She had diabetes. She had type 1 bipolar disorder. She was very, very complicated, and she was struggling with an addiction problem. And he's in the ER saying, what do you think I should do about her lithium? And I thought, wow, this is really complicated. There's a lot of things that could go wrong. And I did the best I could as a general psychiatrist. And I said, you know what? We have a bunch of people in our department who are perinatal mental health specialists. I'm going to see if we can get one of them on the phone. This was on a Saturday evening, I think. I called one of my colleagues. She got on the phone with us. We had a really great 30-minute three-way conversation, and this doctor was incredibly appreciative. I learned a lot. I think that is something that we can do to really help people in our region, and it's been very popular. So I think this is my last slide. This is just a way to try to summarize as a department, how do we try to be helpful? So, we start on the top left. If you're really in a crisis, we have the only 24/7 psychiatry emergency department in our region at our county hospital that we staff. If you need a little bit longer to get well, or if you have both medical and psychiatric problems, we now have a beautiful new facility that the state helped us build on our University Hospital campus to provide that care. If you don't need inpatient care and you're somewhere else in the state, on the bottom right, we can help advise you either through a collaborative care model or through providing you direct telepsychiatry consultation. And then on the left, I didn't talk much about that. We've also built a really nice, with a big philanthropic gift, we built a really nice research institute over the last couple of years that helps us take these kinds of models and study them and say, how do we improve on them? So this was a very quick tour about a whole bunch of different ideas about how could you take a psychiatrist and leverage, or a psychologist and leverage their skills. I showed you all the stuff that I think works pretty well. I can tell you there's lots of things we've tried that doesn't work at all. I'm a researcher. And, if you're really honest, there are lots of things for every one of these things that I showed you that I think work pretty well. There are probably 2 or 3 things that I thought were just as good. And we tried them. And, when you look at it, it just doesn't work. So I think it's really important actually to look at what we do. There's only so much that we have. We only have so much time. So I think we should look and say, is the stuff I'm doing working as well as I think? Because if it doesn't, that's not the end of the world. You just do something different. Anyway, so I'll stop here. I think we have a couple of minutes for questions. Thank you very much for your time.
Thank you very much, Dr. Unutzer. We have a few minutes for questions. If you want to raise your hand and we'll pass the microphone to you, you can answer your question.
Hey, Yates.
Thank you. And thank you, Jurgen. This is so great to hear it put together this way. I was wondering if there's a little bit of extra reflection you might provide on what might be called indirect or secondary benefits of a collaborative care model and their medical outcomes you mentioned, their cost outcomes, utilization. But the one that struck me the most was in your perinatal consultation and collaborative care model. If you make a difference of 10 weeks versus 60 weeks, and think of the impact that that has on the child over that period of time that could potentially be lifelong and profound. So that's just struck me, and I wondered if you could reflect a little bit more.
Yeah, I'm happy to say more about it. So Yates and I are both trained as geriatric psychiatrists, so I don't want to say that it's not important when you work with people in late life. But I do have to say, if you can get to people, when they're very young or even before they're born, you maybe can make the biggest difference. And this was a big eye opener for me because we worked with a group of people here who were, socioeconomically really disadvantaged. They had really serious depression. Many of them had difficult domestic situations, single mothers, people who had domestic violence. And we thought, this is a tough group. How can we help them? And it was amazing. They benefited an enormous amount from treatment, more so than any other group we'd ever tried to help before. Because I think there are a couple of things. One of them is these are, most of them are relatively young, relatively healthy people. And when you're about to have a child or you've had a child, you are really motivated to do well. And there are people around you in your life who are also, hopefully, around you in your life who are motivated to help you do well. And so I was really, really surprised that it could have such a big effect in a high-risk group. And of course, what I don't have is, because this was real world dollars from a county public health agency, I didn't have the money to follow these people. I'd love to see what happens to these kids. I will say one other thing real quickly about this. Early on in my career, I spent time working at the World Health Organization. And back then they had virtually no mental health. It was all about infectious diseases and things like that. And they had a director general who was a woman named Gro Brundtland. And Gro was an interesting woman. She was a family doctor, but she'd also been the prime minister of Norway 3 times in a row. She was a very accomplished lady. And I said to her, I was a very young person, and I said to her, why don't we have more mental health? And she said, if I gave you $1 to spend on mental health, what would you do with it? And I said to her, I would use it to treat a pregnant woman who's struggling with depression or an addiction problem. And she said to me, why would you do that? And I said, you're gonna, if you're pregnant, that child is gonna spend 9 months in utero in an environment with a ton of stress hormones and maybe, drugs or some other things that are bad. And then the baby comes out, and the baby is going to have a different hardware. It's going to have a different brain. And now you're going to have a really fussy baby with a mother who's really stressed out. And there's this thing called attachment that's very important, and it might not go well. And now you have a mother who's going to struggle, and you're going to have a baby who's going to struggle. And when the baby gets into, middle school, is going to be struggling. And now you have 2 patients, and it's a bad situation. And she looked at me and she said, oh, that's a really nice story. She said, is there any data to make any of this? And, back then there wasn't data. There was a great paper that John Bowlby wrote in 1954 to the World Health Organization about attachment and how important this was. But, it was a psychodynamic paper in a sense. It wasn't data to her. And, now we're 30 years later, and all those connections, all those data points have been checked out. And I think that is, if I still only had $1 to spend, that probably is where I would spend my dollar. Sorry, that was a very long-winded answer to this question. Other thoughts, questions?
We do have a question from the chat from Dr. Melissa Heatley. As you mentioned, even primary healthcare is often challenging to access for many. Can you talk a little bit about collaborative care models or capacity building initiatives in non-medicine environments that are frontline mental health facing? For example, I know UW has an excellent school mental health center, the SMART Center.
Yes, you can take mental health anywhere where there are patients. So if you're, when we finished the IMPACT trial, we tried to do a trial with depressed adolescents in primary care. My colleague, Laura Richardson, who is an internist pediatrician, did this trial. And I think it worked quite well, but we realized that, a primary care doctor's office is not where adolescents hang out. Older patients, with multiple medical problems, they're pretty comfortable going there. But, for young, healthy adolescents, this wasn't the place to hang out. So I'm thinking, where are they? They're in the school. At least on a good day, they're still in school. And so we have a center at the University of Washington called the SMART Center. You just referenced that. It's a partnership between our College of Education and our department. And what they do is they say, what could you do like this with a kid in school? There are lots of other interesting places. One of the sites in this Archstone funded study that I mentioned was a place, a program, a community-based program that uses promotoras, community health workers with a high school level education to go and see patients in the Inland Empire in LA, in Southern California, mostly fairly poor Mexican-American immigrant population, many of them struggling with depression. And these community health workers would go into these people's homes and say, I'm here helping to talk to you about nutrition. I'm here to help you with what you might consider sort of more social work tasks. I'm here to help you with, cooking a meal. And we said to those, you're already in the patient's home. These patients are really depressed. What if we taught you how to do problem-solving therapy and behavioral activation? And we trialed that, and we had amazingly good outcomes. 90% of these patients who had diagnosable depression when we started this project were getting essentially nothing but really good evidence-based psychotherapy from a high school trained community health worker, and 90% of them got better. So I think there are lots of places, lots of platforms, if you think of it that way, where you could find a person and engage a person. And if you resource it right, and if you put somebody behind that team who can help have your back when things aren't going well, you can make that happen, I think, in a lot of places.
Thank you very much for a really excellent talk today. Lots of depth and breadth, and we really are grateful. And don't forget to fill out your evaluations. Have a good day.
Okay, do your evaluations. Thank you.